So can everyone see my slides? Yes, I see some nodding heads. Oh,
yes.
Hang on. Okay, hang on. I don't want it to do that. Let's see. There we go. All right. So, yeah, so I just wanted to spend a couple minutes talking about testing for COVID-19. So it's, of course, been in the news a lot lately, and I'm a big public health person, so this is in my wheelhouse. I will say by no means am I a laboratory scientist, so I'm just giving kind of a layman's overview of this. Okay, so I want to spend a couple minutes talking about kind of this concept of surveillance or testing, some different drive-through testing models, some challenges, and then there's supposed to be a conclusion there that I accidentally left off. So just to give you an idea of this idea of disease surveillance. So this is basically, if you are into epidemiology at all, this is essentially a practice where we try to monitor the spread of disease. And ideally, we would catch that disease earlier on and then be able to employ methods such as contact tracing. So basically catching those initial cases, figuring out who they've been in contact with, and then essentially asking those people to isolate or be in quarantine so that they don't spread the disease. Now, unfortunately, in the United States and in other countries, we really didn't do a good job at all of this with COVID-19, which is why now we have so many cases. I mean, we'll get into some of why that occurred. But in an ideal world, we would have caught this a lot earlier and been able to have isolated those cases before we saw the widespread community transmission that we're seeing now. Okay, so again, this is a layman's explanation of how testing for coronavirus works. So basically, if you've seen any of the images, they put a very, very, very long swab up your nose. It looks very unpleasant. If you've ever gotten like a rapid flu test, it is somewhat similar to that. So they put it all the way up into the back of your nose, and essentially that is then sent to a lab. So we'll talk about some different kinds of labs. They isolate the RNA through kind of a series of steps, which again, there's a much more technical level to this, but essentially in order to do this, you need a number of reagents and supplies. And of course you need a lab as it is now. So there are companies that sell these kits. They have been in high demand. Again, another reason why we've had kind of a bottleneck in testing. And then finally, they essentially replicate this DNA, which again requires even more sorts of chemical reagents and supplies. And essentially these dyes are added so that when you're in the lab, you can actually identify the virus and you can tell whether or not someone's positive. So again, very brief overview, a lot more technical details. I'm happy to send you some articles or other readings if you really want to know kind of the ins and outs of that. So if we think about what we've done here in the US, so this is something I pulled from the CDC, I think yesterday. So this is their data on how many people have been tested so far in the United States. And you can see the March kind of 21st through 27th, they are still waiting for further confirmation. So those are preliminary numbers. So that's why it's kind of grayed out. But you can kind of see this evolution of we did very, very little testing, really until we were doing limited testing until it really picked up earlier this month in March. And so part of the reason why is with the CDC, the testing was only being done in CDC labs initially, which again created a lot of bottlenecks. As you can see, not many tests were being conducted. And part of the reason there is they cited kind of this quality control or whatever. So then really in early March, they started allowing other public health labs to process tests. And so that's where we really see kind of this pickup in testing in the United States. So a country that you may have heard about in the news a lot, or just sort of these comparisons. So if you've been watching any of these virus task force updates that they're doing daily out of the White House, then you've probably heard a lot of these comparisons between, well, why has South Korea done so much testing compared to the US? And so Well, a couple things. So first of all, South Korea really were the first ones to implement this drive-through testing center. And so essentially they can do this within 10 minutes. You get the results back within a day. Obviously, you don't get out of your car, and it's free for anyone in the country. And so if you've been following the trends or anything like that, you've probably seen that they comparatively, their cases are actually quite low given their population. And so there's a lot of credit that's given to this early kind of testing and catching these cases. And again, that concept of surveillance so that we can isolate those people who do have it. And so it didn't just happen that all of this was in place. So they had really developed their infrastructure over a number of years to support this kind of testing. So that's a big challenge that we have right now, is that, again, going back to the CDC, they were the only ones doing the testing at the beginning. And so South Korea, MERS, which is actually relatively similar, it's another respiratory virus. And so they had really kind of battled an outbreak of MERS in 2015. And at the time, only the South Korea and essentially the CDC version, South Korean version of that, were the only ones that were doing the testing. And they too saw similar challenges that we're seeing now. And so based on that, they really figured out that this kind of supplies and issues with the logistics were causing these bottlenecks. And so since 2015, they have worked very hard to stockpile these other reagents and supplies that you need to conduct these tests. And that's a big part of why they were able to roll out widespread testing so quickly. So just to give you kind of a idea of this evolution of testing in Birmingham. So this is literally only a couple of weeks ago, so very timely. So basically, if you've been following the news here in Birmingham, week of March 12th, we had 2 sites open, and that was being done by a private lab that had gotten permission from CDC to do their own testing in their lab. And so they set up 2 test sites. You didn't have to have any appointments if you were just showing up. And within a few days, Christ Health, which is an FQHC in Birmingham, and Church of Highlands. So if you're familiar with Church of Highlands, it's like one of these huge mega churches that have a number of sites around Birmingham. I don't know how many members they have, but it's like a lot of people. So basically they came forward and they said, we want to partner with this private lab. I think they're called Quality Assurance is the lab's name. And so they closed their 2 sites down and instead moved to this Grandview campus, which for anybody that's familiar with Birmingham, you know Grandview is down 280, which is already prone to a lot of traffic. And so again, they did not have, you didn't have to set an appointment. So hundreds and hundreds and hundreds of people showed up to this Grandview site and basically shut down traffic on 280 and 459. And so essentially, the people leading sort of this testing effort said, okay, we've got to move to a different place because we clearly can't accommodate the testing needs of this community. So basically, they moved to a different site, and that was a little bit more managed. So then recently, as in like last week, they actually closed that site because UAB said, hey, we're opening our own, and we're opening it downtown, and we don't, from a community standpoint, need you to operate this one anymore. So, which leads us to sort of UAB's model. I don't know about other people, but I was sort of wondering kind of this, what's going on? Why isn't UAB testing? Well, it turns out they were actually working on developing their own laboratory developed tests that they could run in their lab, so at UAB, which is really cool. So basically, they said, you know what, right now we're going to prioritize our inpatients. So they first tested those people because they wanted to see who actually had coronavirus, because if you didn't, they didn't want to keep you in a negative pressure room, right? So you want to keep those rooms for people who actually have coronavirus. And so last week, they opened their drive-through testing site, and so they're doing that with partnership with Jefferson County Department of Health, and so it's a couple blocks from our building, actually. So you have to have an appointment, which, of course, helps them control the site a bit more. And so you have to call first, and I think they have RNs that are manning those phone lines, and I want to think they had hundreds of calls on the first day to try to get an appointment. And so basically, if you meet those criteria, their screening criteria, you then get an appointment. You show up at the testing site 15 minutes before your appointment, and then that way we're not blocking traffic, you're not sitting there for hours, etc. So that's kind of how UAB is doing it. So you can see how that was different from the prior model that we just talked about. And I saw an article the other day, AL.com, who, by the way, has had great coverage of this whole thing, that were talking about how other churches in Alabama are getting very involved in these testing sites. So it's very interesting to watch these things kind of unfold in real time. So you can imagine the effort that it takes to get one of these sites underway within a few days. It's really impressive. So the other really cool thing that ADPH has done, so this is a website, and this was, I think I took this screenshot yesterday, so these numbers are actually higher. But ADPH has put together their own sort of data and surveillance dashboard. So there's two, if you click on this, you actually go to the website. And so I'm not going to click on it because I think my computer's too slow, but basically, if you click on this from the comfort of your home, you can hover over, so these are all testing sites in Alabama, essentially. And so you can hover over each site, and it gives you the details of those sites, like do you need an appointment, what number do you call, how many people have they screened, et cetera. So that's a great resource. You can also, on the same dashboard, you can go to the confirmed cases. So it just breaks it down by county, like where these confirmed cases are, and they update this throughout the day. So just a couple of challenges that have faced drive-through testing. A big one, of course, as I mentioned earlier, we really don't have the infrastructure in order to do this kind of rapid, widespread testing. So part of that is due to those limited supplies, so those reagents that you need and other things, but it's also your PPE. So we've seen a couple of states, particularly New York, that said, you know what, this PPE is so precious to us right now that we're so low on staff that we're really just focused on treating the patients that we have that are in our hospitals, and we're conserving those other things. So there is sort of this probably tipping point when the outbreak gets so bad that you have to really shift your focus. But in terms of, if we're thinking long-term, testing is absolutely the way that we're going to be able to, one of the ways that we're going to be able to get this under control. And once the new cases go down, when we do get those positive cases, we'll be able to use things like contact tracing to see where those cases are, who those people have interacted with, and try to get them to isolate. And then the final kind of challenge facing these drive-through testing is we saw there's just really crushing demand for this. So people, which does indicate there's pretty widespread community transmission of COVID-19. But so that has been one of the challenges of how do you deal with this demand, whether that be phone calls or in the models where people don't need appointments, having so many people show up and sitting in line for hours, et cetera. So, and then here's some references if you want to read more kind of about it. This is where I got a lot of the data. Yeah, so any questions?
No questions?
I have a question. It's Erica.
Yes. Oh, hey, Erica.
I've seen that some places require you to get like an order from a physician first before going to any of the testing sites. Is that like a universal thing, or like do you feel like that hinders the ability of some people being able to actually go get tested?
So yeah, so that is another way people have kind of controlled so basically, for example, there was someone that I know that works at UAB and they felt like they had mild symptoms, right? And so they called the number and were like, hey, how do I, make an appointment? And so basically they were told you need to essentially get an order from your doctor first. And so I think part of it is South Korea can do more testing of people with mild symptoms right now because it goes back to they have the infrastructure in place for this. So I think right now in terms of priorities, we do have this kind of limited supplies, still limited ability to do testing. So I think there's been a lot more priority placed on people who have the symptoms and or are in the hospital because they're more severely ill. So I think our case numbers are way higher, right? I mean, it's just that if you have mild symptoms, it's going to be hard for you, or if you're asymptomatic, to get those tests, again, due to the challenges that we're having with our infrastructure.
And I had one more question too.
Is my opinion, yeah.
How are they is this being charged like people's insurance? Like, do they have to pay for this testing?
So I think that one of the pieces of legislation makes all of the testing free. However, that is a great question because I think there are, I mean, and Mark, maybe you know more about this. I don't know that any of the places that have been doing the testing certainly haven't been paid by like the government, but I think the Church of the Highlands one, maybe you had to pay. So some of them you do have to pay. That is actually another very murky area. So I don't have all the answers to that, but Mark may know more about that.
Thank you.
I know that there are varying ways of doing this, and I think you might want to just articulate in your answer what your proposal would be. Because, for example, if you listen to some of the newscasts recently, some of the health insurance companies have said they're waiving the deductible for anything associated with the coronavirus, including the testing processes. Now, I think many of these testing processes have been done as a public service through the public health department, and you might mention that. Now, as hospitals become more and more engaged in doing it, I think it's going to be shifting a little bit, and you might want to address in that in terms of saying what it is your recommendation would be. Because one of the things that some of the newer testing modalities are allowing is an easier methodology to do it. And that methodology actually might be more moved into some urgent care sites and centers that hospitals own, which might prompt hospitals to want to do it. Some might just do it as a public service. Some might do it simply as that, and again, with the insurance companies basically waiving the fee, I think that's going to be an interesting process to watch going forward. That is a great question, but I think in your responses, why don't you mention what you would think you might want to do? Secondly,